People struggling, people dying. Every day's another headline. While people cheating, people lying, leaving everybody else behind. We can wait for somebody else to come along. We can get on our feet and shout it. Right now is the moment we've been waiting for. Right now, never been a better time. Right now, we ain't waiting for it anymore. Right now, ain't wasting no more time. Right now, right now. Right now, right now. Right now. People struggling, people dying. Every day's another headline. While people cheating, people lying, leaving everybody else behind. We can wait for somebody else to come along. We can get on our feet and shout it. Right now is the moment we've been waiting for. Right now, never been a better time. Right now, we ain't waiting for it anymore. Right now, ain't wasting no more time. Right now, right now. Right now, right now. Right now. People struggling, people dying. Every day's another headline. While people cheating, people lying, leaving everybody else behind. We can wait for somebody else to come along. We can get on our feet and shout it. Right now is the moment we've been waiting for. Right now, never been a better time. Right now, we ain't waiting for it anymore. Right now, ain't wasting no more time. Right now, right now. Right now, right now. Right now.
Alrighty then. Thanks. Appreciate to Steve Carlson for making that song and James Bartosh for making that video. So we'll let people in as we go, but again, thank you all for joining us for this first Organized to Win meeting of 2023. We got some really exciting guests, as you can see. We have John Calabrese. John couldn't make it in person today, but we did record a cool little interview. We have Dr. Laurel Mark. We also have Dr. Gillian Battino, and as you can see, our theme is healthcare. So thank you for joining us on this Wednesday evening. We know that Wednesdays can be tough. It's hump day, and you can be doing anything else, but you're here with us to talk about healthcare and healthcare related issues. So again, thank you all for joining. This is going to be a really cool meeting, and we're going to have some really cool conversations. So just to let you guys know, if there's some questions that you have for any of our speakers today, feel free to put them in the chat and we will try to ask them. And we'll get to them as soon as possible. If there's a lot of questions, feel free to save your question and email them directly to the speakers, and we'll get to them as soon as possible. So again, let's go ahead and get this kicked off. First, I want to start off with a few cool announcements. So if you have not heard, we have made our first endorsements of 2023, and that would be Samuel Harshner and Missy Zombers. So Samuel is running for Shorewood Village trustees. He's a very progressive person. We're really looking forward to getting him elected. We know how important local elections are, considering we live in a gerrymandered state, and this is how we combat that gerrymandering here in Wisconsin. So um, that's a huge, huge endorsement for us. We're really excited about him. We think he has a really good chance of being elected. Our other endorsement that we made early on is Missy Zomber. She's running for Milwaukee School Board, and she's running for an at-large seat. So she's not running for a district-specific seat, and she's a huge proponent of public schools. And we know how important it is to keep our public schools intact and not let our schools be privatized, because we know how privatization leads to a downfall of our public institutions. So really excited about endorsing those two candidates. If you can, please help us out. We're going to be launching text banks for Missy and Samuel soon. So if you can help out with text banks, please let us know. Sign up for a shift, and we can get you signed up and going. Because this is how we create the movement, by endorsing grassroots candidates who are really fighting for working class people. So really excited. Get involved any way that you can, whether that's with us directly or with the candidates directly. We would really appreciate that. So that's one of our big announcements. And also, we are going to talk about our Dunn County referendum pretty soon. But before we get to that, we want to reaffirm why we really, really support Medicare for All here at our Wisconsin Revolution. It's not just a slogan here. So I want to read a little statement that I created for you guys. And the reason why it's so important that we have Medicare for All and continue to fight for it. So, Dr. Martin Luther King Jr. stated, "Of all forms of inequality, injustice in healthcare is the most shocking and inhumane." Now, he stated that in 1966 at the height of the civil rights movement. 57 years later, and we still face the same inhumane crisis today. How can we call ourselves an advanced society when our healthcare system is prehistoric? A system that says a person's health is less important than the profits of a major corporation does not deserve to coin itself an advanced society by any standard. Your level of income should not define the level of care you deserve. How can we pride ourselves on having the best healthcare in the world, yet a study done by the Commonwealth Fund ranks us dead last in a study of 11 industrialized healthcare systems around the world? How can we pride ourselves when 45,000 people die a year due to a lack of healthcare? The answer is we can't, and we shouldn't. We should be catching up with the rest of the developed world, and guarantee healthcare to all of its citizens regardless of their income. We must transition to a Medicare for all system. Medicare for all isn't just a slogan. It's a solution to ending medical bankruptcies, reducing income and wealth inequality, and increasing the freedom for all Americans to determine their own futures. The fight for Medicare for all is not just a morally right thing to do, but it's also the socially and economically right thing to do. So we hope that you can stand with OWR and unequivocally supporting and fighting for what is right. Because when we look back on this time, history will remember who fought for what's right and who stood by the sidelines. OWR will continue to fight for Medicare for all until every American is guaranteed the right to health care. So without further ado, let's go ahead and get started. So I'm really excited about this, our first guest, and that's Dr. Gillian Battino. So Dr. Gillian Battino has been a huge supporter of Medicare for All, and she's also run for state office, which is great. She ran a great campaign, but she's also a mother, a breast radiologist, and a global health worker for 20 years, and passionate about healthcare access. So thank you for joining us, Gillian. How you doing today?
I am good. I'm so happy to be here. Thanks so much for giving me a chance to share the floor with Dr. Mark and with the Dunn County team. I really appreciate just the opportunity to talk frankly about this issue.
Yeah, no problem. We really appreciate you coming. So I'm just going to go ahead and to dive into some questions. And then at the end, if we have any audience questions, please let us know. But the most pressing thing that always comes to my mind is, what is a doctor's perspective when it comes to healthcare? Because we always hear like the human perspective. And I think that's very important about like medical bankruptcies or their nightmare scenarios with their health insurance. But from your perspective, what benefits would Medicare for All bring to hospitals?
So in a lot of different ways. I mean, first of all, I believe very strongly that the patient-physician relationship is detrimentally affected by the cost of healthcare. So the ability to create a trusting relationship between a physician and a patient is so important and imperative to actually creating an environment where the best healthcare can be delivered and patients can trust their care provider. And I run into, with a surprising and upsetting amount of frequency, patients who believe that I benefit quite directly by asking for another study or making a recommendation. And so, and they're not entirely wrong, right? I do work for the hospital, and certainly the bills that pay the hospital also pay me. But if I recommend an ultrasound of the breast, I don't do it because I want to get paid more. I do it because it needs to be done to provide optimal care. And that's a real problem, to have a sense of distrust there, because you go to you take your car into the mechanic and they come up with things that aren't broke to fix. I mean, that's the feeling that you get from your patients sometimes, a true sense of distrust. So I think in terms of protecting that, I consider it to be almost sacred, the relationship that you have with a patient, and that incredible respect and trust that's demanded to provide, good health care. I think that this would really contribute to that. So that's definitely one way.
Yeah, for sure. And one of the aspects that I learned about is the amount of paperwork you get as a doctor. One of the conversations that I had is that with Medicare patients, they don't really have the amount of paperwork that you deal with private insurers. Is that something that would also benefit as far as like the overhead costs and obviously the keeping your sanity as a doctor?
Well, certainly, a lot of your time that could be spent on patient care is taken up with making sure that billing is done accurately, for a number of reasons. I mean, first of all, to be sure that the hospital is billing for the things that need to be billed for, and that's kind of an itemized, detailed, complex kind of problem. But also, making sure that you're not making a mistake and committing fraud in some ways, because that's highly regulated. We've definitely done calculations and looking at what it would mean to remove that middleman and just replace insurance companies with the government. And in terms of efficient, fair patient care, and capacity building, I mean, certainly one of the concerns is that we would wonderfully increase the amount of patients that we have, because people who couldn't afford care would be accessing the healthcare system for the first time. And how do we take the existing workforce and take care of them? Well, if we could remove the responsibility of centering our reporting system and our electronic medical records around making sure that we get paid and just take care of patients, we would build our capacity and be able to take care of more patients and probably do a better job.
Yeah, for sure. And I think the other question I wanted to ask is there's this huge kind of discrepancy of like people don't really understand what the difference is between Medicare for All, which is a single payer system, and public option. And can you kind of explain the difference between the two and what would be the benefit of one over the other?
I'm so glad you asked this question, because I get asked all the time, the path of least resistance and the way to get there is to have a public option. That's what people say. Then you don't upset those who like their health insurance. A public option is problematic in a lot of ways. So first of all, anytime you have a public service competing with a private service, the private service is where capitalism lies. And that's where there are lots of people making lots of money. And it will always undermine the strength of the public service. And I have seen this in action in my global health work, both in Nicaragua and in Guyana, where private hospitals work on the backside and exercise their lobbying, their dollars basically, to keep certain services out of the public hospitals. And then patients, like it or not, end up either not having access to certain services. And I've seen anything from, oh, you can have chemotherapy, but you can't have radiation therapy. That's only at the private hospital. To, you know, you can have a CT scan, but you have to use the old dangerous machine at the public hospital, and you can use the safe one at the private hospital. And so basically, it really detracts from the quality of healthcare that can be provided to the public and to everyone when you have that competition. And then the other thing is that it puts I've seen a lot of stressors put on care providers as well, because it turns out that when you do that, that the providers are paid less at the public hospital than at the private hospital. And they end up, I've seen this many times, trying to work at both. And so they'll say, well, from 7 a.m. to 11 a.m., I'm going to see all of my public patients, and then I'm going to the private hospital because I have to subsidize my income in order to survive by working at both hospitals. And ultimately what that means is that the public patients are not getting the the resources and the attention that they need. They end up waiting for procedures, and they end up waiting for diagnoses and waiting for weeks and weeks and weeks backlogs to be seen. So those are I think some very basic things. And another thing I'll mention is that the presence of the public option would kind of mitigate some of the value, the economic value that is brought by a single payer system. So that is another problem, and it's complicated, and probably Dr. Mark knows much more about how to explain that than I do, but many examples of basically we can pay for Medicare for All or a universal health care program. And when we add the public option, the value of that, in other words, the cost goes up for the public and the value of it goes down for the public.
Exactly. And I think that's some fascinating points that you brought up. And I always find like people say, hey, we have to transition from public option then to a full Medicare for all, because when it comes to precedent, a lot of industrialized countries didn't go from a private system to a public option to a single payer. They went from private to a single payer all at once. It wasn't this kind of transition. So I really think at the bottom of it is a way to keep private insurance intact, and that's really what it's about. The other question I had for you is, I guess it's a little bit different, but it has to do with when you were running for office. You got a chance to talk to probably a lot of constituents, potential constituents and voters. Were you able to hear some of the struggles that they had with private insurance, and what were some of those struggles that they dealt with?
Absolutely. And I think the number one struggle that people report 9 times out of 10 is a deductible that is astronomical. So anything from 5,000 to 7,500, even higher than that, sort of catastrophic coverage insurance with extremely high deductibles, sometimes per family and sometimes per individual. And it basically, they're paying a monthly fee for coverage, and then they have a deductible that is so expensive that it's an enormous obstacle to their healthcare. And people try to manage their access to healthcare around their deductible. So if they meet the deductible because of some situation, then everybody is trying to, get things taken care of before a certain date. It creates a lot of stress and of course a tremendous amount of financial stress, particularly for like where I am. Small family farms struggle a lot with this, where they will have a deductible that's really high. They also have a farmer and a wife who both need to be milking cows, but the wife often, I see this all the time, often ends up working outside of the home in order to provide health care and for a deductible that they can't meet anyway, that they can't afford anyway. So that's the biggest thing that I hear about, that is a clear obstacle to healthcare.
Yeah, for sure. Thank you for that context. We have our first audience question from Jeff Perzan. He said, when Medicare for All or single payer is implemented, how would you use the administrative savings under current private insurance system for Medicare?
So maybe Dr. Mark would better answer that, because I think that the PHNP model is a very good, like the budget kind of model is a very good explanation, and I know she's going to eloquently put that into words, and I might not.
Yeah, for sure. So let me check if there's any other questions. Nope. So the other one is, does a patient's ability to pay for care affect their quality of care? And obviously that's a yes, but if you would like to elaborate on that, feel free to do so.
Absolutely. Absolutely. And it's not that I would change the way I interact with a patient or change my recommendations, but as a physician, I do not have autonomy over the care of my patient. So I'll give you two important examples. One of them is I've had a patient who, three of them. I had a patient who came in with a terrible breast cancer that was ulcerating through her skin. And clearly she knew about it. She was young, young in my opinion. And she told me that she didn't come in because she was waiting for her life insurance policy to mature, because she did not have healthcare and she didn't have anything to leave her children. So obviously she comes in with late stage breast cancer and she's going to die of that disease. So that directly affects her healthcare. Another example would be a patient who comes in with a smaller mass that perhaps is manageable and that she could do just fine with. And I say, I need an ultrasound or I need a biopsy. And there is an alert that comes up on the computer and says, you can't do anything until you send this patient to the finance office, which is, to me, appalling. And then and the patient, by the way, often does not come back once they leave, because it's humiliating, dehumanizing kind of treatment of a patient. And the third example I'll give you is of a young man who was probably in his 30s and had a severe healthcare problem that was causing multi-organ failure, and he was dying, and he needed to be transferred from a community hospital to an academic center or a tertiary care center. And nobody would accept him because they didn't accept his medication, and he died. So that is a real direct, several very direct examples. Sometimes people say to me, oh, 45,000 people die a year, really? And I'm like, yes, really, absolutely, really.
I find that interesting. That's a reaction that some people have, because in the entire Vietnam War, there was only like 50 something thousand people who died in that war, and that was considered unacceptable. But here at home, 45,000 people die a year. Hey, that's just capitalism. It's part of the course. So I think we have to get to the point where that is unacceptable. So yeah, I appreciate it, Gillian. That was amazing. Do you have anything else you would like to add? I'm not seeing any other questions, but I will check just in case. Okay, cool. Not seeing any other questions, but is there anything else you want to add before we move on?
No, I'm excited to hear everyone else speak.
Yeah, we really appreciate it. So just to pivot back a little bit, one of the reasons why we are so staunchly in support of Medicare for All is it's the COVID-19, which was the pandemic, really exposed the flaws in our system. And there was a lot of promises made by the Biden administration that were eventually broken within a few years. For example, free coronavirus or coronavirus vaccine and testing. They were free for a while, but now Moderna is trying to charge over $500 or $100 per vaccine, which is just insane. Normal people can't even afford that. Normal people can't even afford a $400 emergency. So if you're paying $100 per vaccine, that's pretty off the rails. They said 100% of COBRA subsidies for everyone who lost insurance during COVID-19 would be covered, but the subsidies expired in 2021. Yet the pandemic lasts a lot longer than that. He said he ran on going for the public option, but after he won the nomination, he did not mention it at all. And he also said that he would fight to have Medicare negotiate drug costs. But we can see that that did not happen. After months of painful debate, Medicare price negotiations were cut from Build Back Better Act before legislation was abandoned, and insulin costs were capped at $35. So I mean, there's you can read all the ones that we put there, but there were a lot of promises made that were not kept. But these are all issues that can be solved by having Medicare for all. And this is why we fight for it so hard, because this is all a choice. These are all choices that are being made by people who are supposed to represent us. But we're not just talking about it, we're actually doing something about it. So one of the ways that we fought for it was in Dunn County. And in Dunn County, our Wisconsin Revolution and also our Wisconsin Education Fund, we fought to put this on the ballot, and we worked with one of our main lead organizers, John Calabrese, on this issue. And John was not able to come here to talk about this today, but I did do a pre-recording interview with him. So I'll let you guys watch that, and you'll see how we approached this Dunn County ballot initiative and how the question came about and how we accomplished it. So go ahead and roll the footage, Eric. That's to win. All right. Hey, our Wisconsin Revolution family, welcome to the Organized to Win monthly meeting. I'm here with John Calabrese. Thanks for joining me today. John, how you doing today?
Sure, man. Doing well. Good to see you.
Awesome. So the reason why I wanted to ask you to come here today is because you were a huge part of the referendum campaign in Dunn County, in which we passed a ballot initiative in which the question says, shall Congress and the President of the United States enact into law the creation of a publicly financed nonprofit national health insurance program that will fully cover medical costs for all Americans? And I think why this was so significant, at least from my standpoint, was that we didn't really know how this aspect would go and what direction this would take us in. Can you just kind of go through how this campaign started, and how did you guys decide on Dunn County as the first testing ground for taking on this type of ballot initiative?
Yeah, well, we didn't know at the beginning where we would start and if we would start and if this is what we were going to do. And that was the benefit of having a really well-run healthcare committee and bringing in people with a lot of knowledge and background, not in just in the medical field, but in passing resolutions and referenda at the county level. And after a lot of deliberations and many people on the committee not thinking that it was a good idea to do a referendum, maybe a resolution should be better, we decided after some months of OWR developing into its new thing, including having endorsed candidates for the Dunn County Board, Monica Barrier and Andrew Hagan, and then they won their races, and then they got on the board, and then I'm on the board, and then many of our volunteers were in Dunn County. So once we decided on the referendum and the referendum language, we decided, well, let's give it a shot in Dunn County. And it was in the summer last year, and state statute says you have to have the ballot set 60 days before the election. So we didn't have that much time, but that's how we decided to go to Dunn County. And thanks to the organizing of Laurel Vetter, who was part of the healthcare committee and a Dunn County resident, she has been organizing community meetings for years here. And so she has a cadre of people that she can call on. And I don't think it took too much coaxing for people to talk about this all important issue. And she got over a dozen people to come to the first legislative meeting after Laureen's legislative committee meeting after Laureen's insistence, or asking, I should say, of the board to put it on the agenda of one of their committees. So they put it on a legislative committee agenda. Laureen and many of the people she organized came there to testify in public comment. And there was some good debate on that board, on that committee, and I got to offer some good input as a member of that committee, and they decided to pass it along to the full county board, which met the next week. And I don't have all night, but I could get into all the reasons why I think it passed that committee. And then the next week, the reasons why it passed the full county board unanimously. But to summarize why in the aftermath, now that it's over and it passed, I think it's three general categories of why it did well in a rural county that leans Donald Trump, leans red. Was the language of the question, which you just read. We avoided words like Medicare for All or single payer, and those buzzwords turn people away sometimes, and they just weren't in there. That was number one. Number two was the public comment, people from the community being a part of this ask and of this action, and members of the community on the county board as well, to talk to people behind the scenes, to push it through as best we could, to talk about the financial aspects of the county that a single payer, that a national health insurance program would have, the money that it would save. We talked about the financial aspect a lot, and that speaks to rural government officials. And so those were the main categories of why I think it succeeded.
Yeah, for sure. I mean, one of the things that that we really talked about a lot during this kind of whole process was the impact that healthcare has on the county board. And since you're on the county board, can you go into a little bit about how healthcare affects the county budget and why it's so important that we at least entertain the idea of a single payer healthcare system?
The county budgets must be balanced every year. State statute says that the cost of everything is going up. Highway departments are one of the biggest costs to counties. And the cost for materials and salt and equipment are going up exponentially, but the counties are very constrained in how they can raise tax revenue, and the amount of sharing that the state does with the counties has not increased with the cost of living or the cost of inflation. So you add up all the cost of everything that we know, that we all feel in our daily lives, and then you add on to that the cost of health insurance for about 350 employees in Dunn County. They were budgeting about $500,000 a month for health insurance, and that's more than 10% of the budget last year. And that doesn't even take into account a lot of the behind the scenes administrative stuff, all the things that people do to try to find a more efficient and more cost effective system. The time and money that goes into providing health insurance for employees is massive for the county. It takes up so much time, so much money, so much energy. And many of the people on the board and the people who administer the health insurance to our employees, they just go about their business because they think this is just the way that it has to be. And I think changing the conversation was something we said a lot about getting this question on the ballot. And when you could see people on the board, their eyes open up a little bit and they just start to begin to think, what if it wasn't this way? And it's one of those odd things that it's strangling everybody's budget. It's causing anxiety across the nation. And yet we all, for the most part, continue down that line because we can't imagine that there could be anything better.
Yeah, for sure. And I mean, I think that's really fascinating because it's not only Dunn County that struggles with the county budget. It's pretty much every county, especially with the reduction of shared revenue. And I think it really can free up more programs to thrive if we do have a single payer healthcare system. But I want to change the conversation a little bit and want to get to the on the ground aspect of it. So you did a lot of lit drops and got a chance to talk to quite a few voters. What was some of the feedback that you heard from people when you were explaining to them what this referendum was about?
Well, you have to take it situation by situation, and the more people you talk to, the more you go to, you can get a sense of where you want to take the conversation. from the time I started at the county board with this referendum question until the night that it passed in November, not one single person said to me, I think our system is really good and I don't want to change it. Not one person. And so you don't have that to deal with. There were some people who said it sounds like a communist idea and you're a socialist and get off my porch and things like that. That was very rare. But nobody was just across the board happy with this program. And so much like with the board, when you give people this flyer that has the language on it like that, and they start to think about something that could be different, it's one of those rare issues that everybody has a story. Everybody knows someone who's struggling to raise money for medical care costs. Everybody has seen those flyers in taverns that say, we're having a fundraiser because this person got cancer and they can't afford it. And even if it's not a life-changing bankruptcy thing, which there's plenty of, it's just a anxiety-filled stress that we all live with just to deal with the system. And if you don't have health insurance, if you're trying to get your parents into later life care, it's madness. And so when you start from that premise, when you know that most everybody feels that way, and you come to the door not tied to a political party, you're not a Democrat, you're not a Republican, you're a neighbor who is concerned about your other neighbor. What I found that was most fascinating to me was that conversation after conversation, I could see that it was changing from just a discussion of health insurance to a discussion of, I haven't been able to talk to my neighbors these days. They won't talk to me because we don't agree on this, we don't agree on that. And it's really sad. I heard that a lot. And so I think what this campaign can do, in addition to changing the conversation about health insurance, is really helping to mend that divide that the people at the top are getting really rich off of.
Exactly. And I guess my last question for you is, why do you think this movement needs to be continued across Wisconsin, not only in liberal counties, but also in conservative counties?
Because it's similar to my last statement, is that once people, I think that the future of politics, if we have any chance of saving this country, has got to be issue-based, because both parties have been captured by the same corporations at the top, and then all the other factors that keep the entrenched still, and the fact that there's so much profit being made off of our division. If we can find the issues that we all agree on, county to county, and go talk to your neighbors and take that leap into a conversation, understand that it's not going to be a quick thing. It's going to be conversation after conversation. And when people can see this issue and then maybe think that it could be different, then maybe they'll think the same about other issues. And so I think it's not only important for the health insurance campaign, it's imperative for grassroots movements to actually affect real change in all avenues at the ground level.
Sure. And there you have it. That's what was done in Dunn County, no pun intended, to get national health insurance passed on the ballot and in the November election. So it was a very inspiring movement, and I think it can continue across Wisconsin, and I think our Wisconsin Revolution can lead that way. So thank you, John, for coming on to Organize to Win this month, and hope to keep you in contact with our Wisconsin Revolution.
Indeed, we'll stay in touch. Thank you, Andre. Thanks, everybody.
So that was the interview with John Calabrese. So sorry you guys can't ask some direct questions, but as you can see, that movement and what we did in Dunn County is something that we're trying to take across Wisconsin. So we're going to be having some meetings. Specifically, our Wisconsin Revolution Healthcare Committee is going to be meeting this Sunday at 2 p.m. So if you can make it, we're going to be talking about some of our plans to further this movement that we started in Dunn County and how we want to go about that. But in the meantime, I want to get to our next guest speaker, Dr. Laurel Mark. Dr. Laurel Mark is a retired internal medicine and primary care physician in Madison, Wisconsin. She's a longtime member of Physicians for a National Health Program, or PNHP, a professional organization of physicians who do research, education, and advocacy for single-payer nonprofit health insurance for all, and was the chair of the Wisconsin chapter from 2019 to 2022. She is an active speaker on single-payer and the privatization schemes currently threatening our fragile healthcare safety net. So, Doctor, thank you for joining us today. I'm really excited to have you on today. How are you doing today?
Great. Thanks so much for inviting me to join you.
Yeah, we're really excited. So one of the main reasons why I wanted you to come on here is to talk about a very, very underreported program that has pretty much slipped through under the radar, and that's the DC/Echo Reach program. Can you tell us a little bit about what it is and how it was created?
Sure. This is actually a very scary program, and I think of it as like this is an existential threat to Medicare and to the trust that we have put in the last 57 years into our public system. That is completely under the radar, and most people are unaware of it. But if left intact as it is going now, it really will destroy Medicare. And then we will not have the opportunity to fight for Medicare for all, because we're going to have to rebuild the entire system. So this is pretty new, and we have some opportunities, I think, with education and advocacy to push this back. So this program actually began at the very last year of the Trump administration, and it is a super privatization scheme. I want to step back for a minute and just explain basically how Medicare works, in case you don't know, which is Medicare is the system that was initially put together to ensure ensure senior citizens, people over the age of 65. It was passed on the same day and signed into law on the same day in 1965. So as Medicaid. Medicaid is the program for poor people, pretty much, disabled people. Medicare is the system for older people and a few specific diseases. Traditional Medicare is a government-run program that we all pay into every single paycheck. Or if you're a person who pays income tax, you pay it as a self-employed person. It used to be called FICA on your payroll stub, and now it is actually called Medicare. So every one of us who has ever earned money or paid income tax has paid into this system. And traditional Medicare, then it's a federal government program that then pays medical providers, physicians, hospitals, labs, etc., directly. It is the same program throughout the entire country. Your benefits are exactly the same, whether you're in Alabama, Alaska, New York City, Madison, Wisconsin, Dunn County, wherever. And it has no networks. You can go anywhere. You can see any doctor, hospital, clinic that takes Medicare. And currently around 95% of American physicians are in the Medicare program. It has a lot of problems. It has some gaps. You know, when you talk about Medicare for all, we talk about PNHP, we call it improved, expanded Medicare for all, because we would need to fill those gaps. But that is what traditional Medicare is. Medicare Advantage is a program that was started about not quite 20 years ago under the George W. Bush administration, which began the process of privatizing Medicare by allowing for-profit health insurance companies to market managing the Medicare funds for patients under their program. And what's different about this new program is that Medicare Advantage is one where a Medicare recipient can choose to be in Medicare Advantage. I would call it Medicare Disadvantage or Medicare taking advantage of you. It is a very glitzy program. We can talk about that at another time. but at least it is marketed to patients and people make that decision. This program, what is now called ACO REACH, and this is kind of Orwellian kind of language, I should tell you, was begun at the end of the Trump administration. And what it aims to do is to privatize what is left of traditional Medicare. When Medicare Advantage began around 20 years ago, it was a tiny pilot program. It is now, as of last year, 47% of all Medicare recipients are on a Medicare Advantage program. So it's about half. They've taken over about half. What ACO REACH intends to do is to privatize the rest of it, is to take away the rest of traditional Medicare and give it to private equity firms and to for-profit health insurance companies, and in some cases to the quote nonprofit health organizations. So it is a pretty insidious program. It is also not marketed. The reason you don't know about it is it's not marketed to patients. So you're not seeing glitzy ads about it on television, and your grandparents and parents are not being asked to join it. They are specifically targeting it to medical facilities and to doctors. So they're signing up doctors. So originally it was called direct contracting entities. There was a fair amount of pushback in especially in the single payer world against it, but also a lot of other medical advocacy and healthcare advocacy groups came together in 2021 to fight about this. And what they did was they renamed it. And they, instead of calling it direct contracting or DCEs, they now call it ACO REACH. So ACO stands for Accountable Care Organization. This is, I don't even want to get into what that means, but it's a shorthand for kind of an old discredited HMO type approach to healthcare. And REACH is really an Orwellian name. It stands for Realizing Equity, Access, and Community Health. And doesn't that sound nice? The problem is that this program does nothing to realize equity, access, or community health. What it is it's a scheme where instead of the federal government, the Centers for Medicare and Medicaid Services, CMS, which pays the bills for Medicare, directly to doctors and hospitals, et cetera. Instead of having that happen, they insert a middleman in between. That middleman can be a private equity firm, it can be a health insurance company, it can be UW hospital systems, it can be Mayo Clinic, it can be every big hospital system that wants in on this. And that middleman, with all they're doing really, they're providing no health care. These are not health, most of them have nothing to do with healthcare. They're private equity firms. What they do is they are getting the money directly from Medicare and they will pay the doctor. So Eric, there's actually, I think the other slide that you have shows that better, because traditional Medicare pays the providers directly. Direct contracting REACH, ACO REACH, pays a middleman to manage care. This is a really discredited idea. So what are they going to do to manage care? There's really only one way. There's only a few ways that a private equity firm or a for-profit health insurance company can make money off of this system, and there's no other incentive for them to be in it. And that is by getting more money out of Medicare and then paying less out. That's how health insurance, that's how a for-profit health insurance company works. So there's a number of ways in which they can get more money. They can get more money by, there's a complicated system, but Medicare figures out for how they pay out based on coding the severity of people's illnesses and the different kind of illnesses. And the health insurance companies are very good. They have learned how to game this system over the last 20 years. They know how to code in a way to get 4 to 5 times what is actually valid for, and it's still legal, but valid for the problem. And then they decrease money they decrease the money spent on patient care. And then they'll increase the volume through enrollment. The patient may not see that right away because this is done through the doctors. And even the doctors may not see that right away because private equity firms have a history in many industries, but specifically in healthcare, of promising a whole lot of advantages to the hospitals, the clinics, and the doctors who participate, and the practices that participate. And then once they have extracted the money that they can from the system, they tend to abandon it. It's a very bad track record. And so to apply this to traditional Medicare is a real issue.
So
This
I
was
do have
really
a question.
created as a profit stream for private equity firms and health insurance companies.
Yeah, it's extremely disturbing. And the question I have for you, and obviously we're just speculating, is this was started under the Trump administration. Why do you think the Biden administration continued this horrible, horrible scheme that you would think Democrats would be full out against, yet they are full out in favor of? Why do you think the Biden administration is continuing this program?
Now, this is really, it's really very distressing, actually. But before I answer that question, I just want to say two other things. The other thing that's different about this is than Medicare Advantage, it's kind of Medicare Advantage on steroids, is that as a Medicare recipient, I am a Medicare recipient, I have no control over this. I cannot opt out of it. If my doctor is part of this program, I am part of the program. There is no way I can opt out of it. The only way to opt out, and this was told to us by the head of the CMMI, the part of Centers for Medicare and Medicaid Services that administer this, that if you don't want to be in the program, you can find another doctor who's not in it. And I don't know about you guys, but it's very hard to find another doctor these days, anywhere in the country, anywhere in our state, not just in rural areas. Plus, the idea of this program is eventually meaning within the next 6 to 7 years, expand it to all of traditional Medicare. So there will be nobody to opt out to. So that is really a problem. And so it's being done without your consent, without your knowledge. It's just being taken over. So why is this being continued? That is a really good question. I think a big part of this is that nobody knows. When we started, when this became known, most of the congressional representatives we talked to had never heard of it. These are deep in the weeds kind of decision making within CMS, within the Centers for Medicare and Medicaid. There is one of the reasons that this can continue is that the specific office that administers this is shielded from congressional oversight, and they're shielded on purpose. This is an office called CMMI, the Centers for Medicare and Medicaid Innovation. It actually was created as part of the Affordable Care Act with very good intentions. The intention was to isolate, to be able to do innovative programs for both payment and for services without having Congress have to vote on every single thing, so that when control of Congress goes back and forth and these very, very right-wing majorities versus a Democratic majority or something, that you wouldn't be year by year changing the program. So because of that, actually, Congress does not have the ability to just shut it down. So part of the reason why is that people in Congress don't know about it. They're beginning to know about it, but there's still a huge amount of education to do. So last year, the Congressional Progressive Caucus, which is about 110, 120, or was actually in 2021, about 120 representatives, when they put their list of priorities together in March of what they wanted to get accomplished, the number 2 thing was to dismantle this program. Didn't go anywhere. And part of the reason for that is that the people who are currently Biden appointees, currently running HHS, Health and Human Services, and CMS, are believers in the for-profit system. They don't believe in single payer public Medicare for all. They really are true believers that a for-profit system is the way to move forward here. I think a lot of this obviously has to do with money. That think about all the lobbying that goes on in Congress from the health insurance companies, from the pharmaceutical industry, from the medical material providers and stuff. I mean, they fund the campaigns of our congressional reps and senators to a very large degree. And they have a lot of loyalty there.
That's what it
I
comes
don't
down
know.
to.
And then Biden, Biden himself is not a single payer guy. So, but I still don't, I mean, deep down, I don't get it. Like why they don't see the risk that's involved in this.
Well, that's what happens when you got money incentives to look the other way. But we're kind of running out of time here, and that was great information. Thank you, Laurel, for giving that to us. And I'm sure there's so much more to go into when it comes to this. Where can people learn more about this if they want to get connected with you or learn more about the Echo Reach program?
I think this is really, I think it's actually very important for our revolution, our Wisconsin revolution, to talk directly with our allies, both at the state and at the federal level. These are federal programs, so we want to talk specifically to our federal allies, to our congressional reps, our senators, because I think there's a huge lack of information here. And I know that Andre and Eric and I, we talked about this a little bit earlier. There's, in response to a lot of the advocacy that has been done to try to stop this program, the health insurance industry has really been fighting back. And one of the things that they did was they got a letter together and got, get this, 80% of congressional reps from 2021 to sign on to a letter strongly supporting the Medicare Advantage program. And this includes staunch members of the Congressional Progressive Caucus who should know better. But since they don't, I think it's our responsibility to help educate them about that. So I'm talking about people who you would never, it's sort of as if Bernie Sanders was in favor of for-profit Medicare for All, Medicare Advantage, which he's not. So the first thing is just do some education for yourself. And the best way to do it is to probably go online, look at the PNHP website, there's a website called protectmedicare.net, which has a lot of this information on it. And there's like actually in both of those places, there's a toolkit which has information, sample letters to information to share with your congressional reps, letters to the editor. Organizations can sign on it to our work in opposition to this. Individuals can sign on. Spread the word around people who are on Medicare. I think the only way out of this is honestly to convince our representatives to put a stop to this.
Yeah, for sure. Really appreciate it, Dr. Laurel Mark. So let's stay connected. Thank you for giving us this vital information, and we're going to continue to fight on this. But like I said, we're not only talking about this, but we're taking action. But we can't take action by ourselves. We need you guys to get connected. So ways you can get connected with us and get involved and take action is one, signing up for our email list. This is how you stay up to date on what meetings we're having, what actions we're taking, what events we're taking part of, what partnerships we're having, such as PNHP. So that's one good way, but also come to our next
Andre,
healthcare. Yeah.
Can I interrupt you real quick?
Yeah, go ahead.
Right in the middle of that. Oops.
I was on the wrong device real quickly here. I just wanted to say real quickly, at this link at the top where our action toolkit is, there are links to do all of these things at this link right here, bit.ly/Jan23OWR. Literally, you can just put that right into Google and it'll take you to our action toolkit, which not only has links to do all of these things on the screen, it's got some resources, including the Protect Medicare link that Dr. Mark just said, including the Biden-Sanders task force plan that came out of the campaign a few years ago. Lots of information about all this stuff is summarized in that toolkit, as well as these actions that Andre is talking about right now. So that is bit.ly/Jan23OWR. It's right up on your screen right there. Go ahead, boss. Take it away.
Thanks, Eric. Really appreciate it. So yeah, just follow what Eric said, and also come to our next meeting. So our next healthcare committee meeting is actually this Sunday, January 22nd at 2 p.m. I stated that before, but there are emails that are sent out. So RSVP. And also, we have a petition going around that we're working with and partnering with Poor People's Campaign to protect Medicaid. If you don't know, a lot of people are about to get kicked off of Medicaid because the exemption or the program that expanded it through the coronavirus, that is about to expire and end, and that's a huge problem. A lot of people in Wisconsin are going to be subject to be kicked off, so we're going to present some petitions to help them get that around. So that's another way, but we're also going to be doing a petition ourselves, telling your member of Congress to support and co-sponsor Medicare for All. That's going to be reintroduced this session. Obviously, our end goal here, we want Medicare for All, full stop. We know that's the solution to everything we are doing. So that's a huge way. And also just tell your friends and family about this. A huge way for us to expand our movement and our network is word of mouth. We don't have the huge budget. You know, we're not sold out to billionaires. So a lot of what we do is grassroots word of mouth. So follow us on social media, get connected with us, and tell friends and families about upcoming meetings that they can join. So that is how you can impact this movement. And this is how we take it to another level. So I want to thank you all again for coming on this Wednesday evening. I want to thank the guest speakers for joining and taking the time out as well. So again, thank you all again. We're going to continue to organize, and Medicare for All is the way and is the solution. So everyone have a great rest of your night, and let's continue to work.
Thank you.
Have a great day. Thanks,
Thank
Gillian.
you.
Thanks, Laurel. It was
Yeah,
great.
thank
Thank you, everyone.